to determine the mechanism of injury, understand the fracture biomechanics. How do you assess radiologically the complex proximal tibial fractures, the classification, and the temporary as well as the definitive treatment options. So let's all begin slowly and steadily. So proximal tibial fractures is one of the most critical load-bearing areas of the human body. So what is the goal? Restore the joint congruity, get all the broken pieces together, preserve normal mechanical access, get a stable joint, and restore the knee motion. So these are the basic things what you need to do. Restore joint congruity, preserve normal mechanical access, stable joint, and restore knee motion. So what are the issues with the proximal tibia fractures? Why is it so different than any other fracture in the body? The reason is the severe comminution, variable bone quality, overlying soft tissue, injury associated with the cartilage, meniscus, and stabilizing fragments. So these are basically all the things which play a very important role. Many of the times the underlying medical condition does not permit extensive surgeries for the patient, and the most important in our region is the financial background. So how does it fail? The proximal tibia, how does it fail? The mechanism described are the varus valgus deformation, the axial compression, and the direct trauma. Basically, it is subjected to a lot of varus and valgus stresses. So if it exceeds the bone strength, it gives way and a variety of fractures occur. So the most important is the concept of dish and dome. So now if you can see here, on the medial side, there is a concave dish, whereas on the lateral side, there is a convex dome. So MCD is a medial concave disc and the lateral is a convex dome. So axial load transmission on the medial side leads to split fractures in a mediolateral direction. Medial is concave. So whenever a femoral condyle goes in, it causes a split in a mediolateral direction. Whereas on the lateral side, whenever the compression occurs, there is a multifragmentary depression and widening of the condyle because the lateral side is the convex side. So this plays a very important role. You need to assess the personality of the fracture, such as soft tissue damage, degree of dislocation, comminution, joint involvement, osteoporosis, and the nerve and the blood vessel injuries if there are anything. Absolutely essential. Be very methodical when you have a patient with a proximal tibia fracture. We have to evaluate the patient in the terms of soft tissues, neurologic status, vascular status, and the overall stability. You might come across patients with blisters like this, which indicates a deep insult into the soft tissue. We have to go for an X-ray, a CT, and an MRI just to see the meniscal status. So what do you see? An axial is used to classify the three-column concept. The sagittal is to see the shearing injuries, and the coronal cut is important for determining the impaction and the comminution. So these are absolutely essential. What are things you need to see? On an axial, you see what column of the proximal tibia is gone. In sagittal, you got to see the shearing injury, the shearing pattern, whereas in coronal, you see the impaction and the comminution, because most of your treatment and surgical strategies are based upon the CT. So we have the classification of Schatzger, which we have studied, the AO-OTA classification, which has been popularized for quite some time. But now there is a three-column classification, and by the time you pass out, there might be one or two more. So the AO-OTA classification is basically extra-articular, partial articular, and complete articular. And depending upon the severity of the entire thing, it keeps on changing. So we have a simple one to a more complex one, which is the 41C articular multifragmentary. Irrespective of that, we are used to the Schatzger classification, which has increasing severity from the lateral to the medial. So as you can see here, the type 1 is a split fracture, type 2 is a split as well as depression, type 3 is a central depression. Now, if I go from Lowe's three-column concept, So these two comprises of only one column. So this comes to be a one column injury, may not be so severe as we move on. The type 3, which is a central depression fracture, is a zero column. Now, as we move to the severity increases, we have a type 4, which is a split fracture, medial plateau predominantly involved, and the type 5, which we call as a bicondylar tibial fractures. In type 6, we have a dissociation of the metaphysis and the diaphysis, one of the most serious forms of a fracture. Now, type 4, it comes is a two-column fracture because when you see a coronal section, and type 5 and 6, they comprise of the three-column fracture. So now here what I was talking about. And now this is a three-column concept which has a center is passed from this point, from the anterior aspect of the fibula to the center, and from to the midpoint of the anteriormost point of the medial tibia, and from the lateralmost medialmost point. So this divides the proximal tibia into a medial column, lateral column, and the posterior column. So the one column is equivalent to a Schatzger 1 and 2, which is an articular depression in the posterior column with a break in the posterior wall. Okay, so this type of fracture was not included in any type of a Schatzger classification. This was a very, very important point. Now, in type 2, which is a Schatzger type 4 column, the Schatzger type 4, the anterolateral fracture and a separate posterolateral articular depression with a break in the posterior wall. So this comes to be a 2-column or a Schatzger type 4. So now, when we see a type 3-column fracture, it is defined and so independent that each column has got an injury. Is defined of at least one independent articular fragment in each column. So that is the reason why it is the most severe form of a proximal tibial fracture. So now, I don't know. So now the surgical tactics, what you want to do, what you want to achieve, what you want to aim is to obtain an articular reduction. You can do it by a direct visualization. You have to reduce the condylar width because many a time when even the lateral condyle is also fractured, the condyles just play. So you got to reduce the condylar width in line with the femoral condyle above. You have to restore the axial alignment and you have to have a fragment-specific fixation. So while I was studying, while I was preparing, the thing which commonly comes into the mind is the mnemonic, which is the length, alignment, and rotation. So LAR, length, alignment, rotations, which also involve an element of articular reduction. And after you have achieved all this, you go for a fragment-specific fixation. So for a fragment-specific, we can go for a medial and lateral plates. We can buttress the articular fragment. We have a lateral fixed angle plates. We can neutralize the metadiaphyseal fragment, and we can secure the tibial tubercles. So these are all the options what we have where we can change the way they come up. So the implant options are related to the fracture pattern, degree of displacement, and the familiarity of the surgeon. Now I stress the point familiarity of the surgeon. So now plating and screw, what do? They cause the buttressing against the shear forces or neutralizing rotational forces. You can use a thinner plate, can use it by MIPO technique as well as double plating. You can use only screws when the fracture is a simple split fracture, or there is a depressed fracture elevated, which is elevated percutaneously, and a sort of a raft mechanism. You can just let the screws do their role till the articular surfaces, they form or they glue up or they heal. And external fixation is one of the wonderful techniques in the armamentarium of an orthopedic surgeon because it helps in gaining the time. Now, as we move on, the treatment options for Schatzger type 1, which is predominantly a lateral column fracture. So what we do a close reduction. We use an anterolateral approach. We use a 6.5 mm cancellous screw or a lag screw with a washer to gain compression. As I told, splaying of the proximal tibial condyle is not at all acceptable. And in a young patient, a screw fixation is quite adequate, young patient. You can also use an anti-glide plate and screw, and in elderly, a buttress plate is absolutely essential because you can't predict the way their bones are going to be. You can use either a screw or a plate. So now we move to the Schatzger type 2 or the lateral column. Now the mechanism is a split depression. Valgus and extension mechanism is the reason. So split depression fracture. So what you've got to do is to get the things in alignment, lift it, and then pass a plate. If you see the CT, you can see a big void here. That big void is the thing where your bone is crushed, is lost, and you need to reconstitute something of that sort to get the things back in position. Now, Schatzger type 3 or the zero column. As I told you, it is just a depression in the articular surface. So now, what you need to do, you can do it either by open reduction or an arthroscopic assisted one. Go for an anterolateral approach, elevate through a metaphyseal window, pass temporary K-wires. You can use a subchondral plate or screw, and there are proponents of bone grafting as well as those who do not agree to it. So this is the important thing in Schatzger type 3. Now, when we go to type 4, so this is where the severity of the injury starts increasing. See the amount of impaction, amount of injury which has caused this type of a devastating injury. Now, if you see there is a split fracture of the medial tibial plateau. And now, if you see the CT, the axial section, you can see the coronal section, you can see all the columns gone. So this is the varus and the flexion mechanism. And you can see a nicely done surgery where all the columns are addressed and the patient went to an eventual union, a wonderful union. Now coming to Schatzger type 5, now here what we got to do is we have to stabilize. It's a bicondylar fracture basically, it's identical to this, what it is. So what you got to do is you have to use a double plating. You can either use a locking plate or with an external fixator, where you can either use a definitive external fixator or you can go for an Ilizaro. So as I said, depending upon your preference, the way you have been trained, the way you feel is right for the patient, these are all the important determining factors where you are going to give justice to this complex and devastating injuries. So now as we move on to type 6, the metadiaphyseal dissociation, the fracture which is one of the most serious fractures. There are two incisions, the anterolateral and the posterior medial incisions, most useful to address the majority of the proximal tibial fractures. The aim is to address the posterior medial fragment, the medial articular involvement, and the displacement of the medial column. So as we move ahead in this talk, you will come to know why the posterior medial fragment is most important. So now this is the fracture which has fully healed. A nice, good farmer who often brings vegetables to me whenever he comes from his village. Now, this is also a way by which this procedure can be done by my friend Dr. Reddy from Warangal, who does majority of the proximal tibial fractures by an Ilizaro apparatus. Wonderful things, but you need a lot of patience. The patient has to be cooperative. You need to be trained enough to do it and manage all the complications. So, as I said, the posterior medial fragment, why it is important and how it fails. Now, if you see this posterior medial fragment here, this is the avulsion fracture of the semimembranosus tendon insertion site due to stress on the knee joint in hyperextension. Suddenly your knee is hyperextended, so it causes an avulsion fracture of the semimembranosus tendon. So there is a split fracture. The knee is subjected to vertical or a varus stress in a flexed or a semi-flexed position. So now imagine the vector forces in all the different directions. The vertical or the varus stress in flexed or a semi-flexed position. So, and whenever the stress is violent or in combination with a torsional force, the tibia has a tendency to dislocate anteriorly from the femur, which may in addition lead to an ACL injury. So this is an absolutely essential understanding, and most of the time it has a large surface. Around 58% of the area is of posterior medial fragment if you see a cut section. You can appreciate it here. And around 23% of the entire articular surface. So this makes it absolutely mandatory, absolutely essential to plate it, to buttress it. Okay? It is the posterior medial fragment is a vertical split fracture and not a compression fracture, even in osteoporotic bone. So this is a point what you need to really keep in mind. So irrespective of the age, the posterior medial fragment always has a minimal amount of comminution unlike the lateral tibial condyle. So approaches, how do you approach? We can go from the anterior approach, you can go from the anteromedial approach and the posterior approaches. So there are many approaches. The damage to the soft tissue is caused by dissection. You have to understand that. Obstructing exposure of the fracture fragment is also an important point. There is a lot of soft tissue trauma and injury to the blood vessels. And the risk of injuring the neurovascular structures, they are always there. So this is one of the most important points whenever you are tackling any of the posterior medial injuries, any of the posterior medial injuries. So fixation, how do we get along with it? The outline of the posterior medial tibial plateau is very, very irregular. Just appreciate this thing. Just appreciate this. See how irregular they are. The transition zone of the metaphysis has a great curvature. See here. See, suddenly the curvature is more. And the buttress plate fixation, hence, is mechanically a strong one. And as you can see here, this was a combination of the two cannulated cancellous screws with a washer and a posterior medial buttress plate. So this buttress plate has to be at the apex of the fracture. We also have the different posterior medial fractures. You can see here significantly a big fracture. Buttress plating has been done. An additional screw has been passed. The fragment sits in place and eventually the patient gets good movement. Now, as you can see here, he was a auto rickshaw driver and was able to do many things on his own. You can see the scar there. A wonderful physiotherapy was essential, which he did. So now we go to from posterior medial, we go to the posterior lateral fragment. So now the valgus and axial compression forces with knee inflection is essential. Valgus and axial compression. So the fracture line primarily and mainly on the posterior aspect, and lateral condyle continuously in a coronal plane. So as I told you in the early part of my lecture, so medial side is a concave and lateral one is a convex. So whenever a femoral condyle dashes inside, it causes splaying. And all the cases need bone graft substitute as the diameter of the metaphyseal defect is always more than 1 centimeter. So as you can see here, there is a lot of small comminution. There are small pieces, but they are pretty important pieces which you should not be neglecting. And now the posterolateral fragments have been buttressed. So basically you got to get the fragments in position, getting the articular alignment in position. So now why ask for a CT scan? Now this is such a devastating injury. Someone asks you, why do you need a CT? Why? So these are all the reasons which I again would like to stress. So a depression of 6 millimeter and a widening of 5 millimeter has an increased likelihood of a lateral meniscus injury. Whereas a more depression of 8 millimeter and a widening of 8 millimeter leads to a medial meniscus injury. Absolutely important points. The concept of circumferential approach. So now what exactly does this do? The upper tibia has got fractures all over. All the columns are shattered. The walls are shattered. So what do you want to do? It uses the 1 and the 3 incisions between approaches between the 1 and 3 skin incisions commonly used. So multiple windows, you respect the angiosomes so that the blood supply of the proximal tibia is not disturbed. And at the same time, you can do the internal fixation through the safe windows for a stable construct in all fracture patterns, respecting the ligament and muscles supporting the knee. So this is absolutely important concept whenever you do a proximal tibial fracture. So the message, the posterolateral and the posteromedial fragments play a very, very important role. Avoid the old midline anterior exposure, which is no one followed in the exposure, no one followed nowadays. No literature backing what is good, whether ORIF, hybrid, circular external fixation, or unilateral locking plate. No literature backing what is good. You have to delay weight bearing as far as 6 weeks, but you can initiate physiotherapy as fast as possible. So surgery, why and when? A joint instability of more than 10 degrees, varus valgus anteroposterior, articular malalignment of more than 10 degree varus valgus, and repair the meniscus whenever possible as against removal. Always remember that thing. So the take-home message, fully understand the fracture morphology. It is essential for decision-making and definitive fixation. Approach, selection, and fixation should take into account the soft tissue mechanism of injury and the 3D morphology, and a 3-column classification provides a new way of thinking in the management and the treatment of the tibial plateau fractures. Thank you very much, friends. I'm sure this must have definitely thrown some light on the concept of the proximal tibial fractures, and I'm sure as you move along, you will start developing an increased liking for this complex proximal tibia fractures. Thank you very much for being there. Thank you.